All right, Joyce, thank you. Can you hear me okay?
Absolutely.
Awesome. Well, thank you for the introduction. What I'd like to do this evening, it will go over an hour. If people leave prematurely, I will take no offense. Those that do have the time to stay, I promise to make it worth your while. um, my hope today is to hopefully change not only your career and your life, but the perspectives of your patients and the lives of your patients. This is a topic that many of us have attended at conferences, maybe at Yankee or other seminars and conferences. My goal today is not necessarily to follow and do what's already been done. Dr. John Comissi did a very nice introduction to this topic about a year ago. My goal is to help you maybe implement this tomorrow. That's the objective of today. So again, the topic of the lecture, implementing oral sleep appliances into your dental practice and why it matters. So like I just said, we're going to dovetail this presentation with Dr. John Comissi's Airway Sleep-In lecture from last year. We would also like to talk about whether this is right for you in your practice. We've all attended CE events over the weekend. we saw the presenter provide some really nice cases, and we thought on Monday morning we were going to be doing that same level of work. Well, as we all know, Monday morning happens and we forget all about the weekend. My goal today is hopefully to provide you some documents so that if and when you do pick up on this stuff, you can pick up where we left off from this conversation. To do that, I'm going to provide actionable flowcharts, checklists, and protocols for your practice, your dental practice. But most specifically, I want to provide a solution for the patients that live in your practice, primarily the mandibular advancement device, which is one tool that we can use to treat patients with sleep apnea. 90 minutes, I promise this is going to change how you see your patients. At several points in the presentation, I'm going to be referring to something called the Miro board. The Miro board is a tool that you can use. I use it personally and professionally. Miro.com is where you find it. I have no financial interest in Miro. I just think it's a wonderful place to dump ideas, workout ideas, and what I decided to do was use that here. This also dovetails with something called New England Center for Advanced Dental Education, which I'm part director for. This particular flowchart and the way we are hoping to teach different dental concepts could be found there. So if you want access to this Miro board, you can go there to find it. Just click on Miro boards and dental sleep medicine, and you'll have access to this. Now, this is a live document. What that means is as I add stuff into it, you will see updated forms. For example, ADA policy statement on dental sleep medicine, I have that here. So if you click on this underlined link here, it will bring you to a Google document that will that you can download and you can modify and use as you see fit. As you can see, there's all kinds of underlines here, and all throughout here, there's resources for you to, if you decide to after today, start in your dental sleep medicine journey, these tools will be there for you. The PowerPoint presentation can be found on this link right here. Again, we're going to come back to this. I'm going to go through this in great detail. I just wanted to let you know when I'm talking about the Miro board, that's what I'm talking about. If you'd like, there's a link right here. Nora will be sending a copy of the PowerPoint presentation, but I'll make sure that she has my email and the Miro board link in that email that she sends tomorrow. So a few highlights, just because I'm taking the baton from Dr. John Comissi, I wanted to make sure that I share with those that didn't see him what he talked about. He made a very good case that oral appliance therapy works. We can think of mandibular advancement devices and OATs as the same thing. There's an unbelievable amount of scientific literature supporting their use in medicine and dentistry, and very little saying they don't work. So if that thought is in your head, hopefully we dispel that tonight. He talked a lot about the importance of sleep, both quantity and quality. The more and more we understand disease, the more and more we understand the importance of sleep's role in systemic diseases. He talked about sleep studies, polysomnograms. These are the tools that sleep physicians use in order to gather data about the quality and quantity of somebody's sleep. This isn't something we're necessarily going to go over, but you should be kind of aware what's on the other side of the fence. The sleep physicians use these tools to provide diagnoses. He talked about the pharyngometer and the rhinometer. These are both really wonderful tools. Unfortunately, they're expensive. My goal today is to provide you with an alternative to this, but I just wanted to mention he did talk about these. Probably the most important thing that he alluded to was his, I don't know if I can give him credit, but I'm going to, for discovering, or at least being one of the first to publish the fact that the vertical component, you'll learn a lot about what I mean about this. I just wanted to bring it up here. The vertical component of the mandible is actually at the same level of importance, if not more important, than the protrusive or the horizontal component. And he published that in the Journal of General Dentistry August of 2020. I will have a link to that also in the Miro board. I highly recommend you take a look at that. And the last thing, he made a very good point, something that, you know, I think he emphasized in my head. We should never treat patients that snore. We're not treating snoring. If patients snore and they have quality of life issues, we're referring them to get a sleep study. Please do not fall into the trap of making snoring devices for patients because you think that, well, snoring is not a real medical condition, therefore I'm safe. That's very untrue. You're more likely to hurt the patient than you are to help them. Please revisit his lecture if you want to learn more about that. But I hope to paint that picture tonight as we move forward. Well, as with all new concepts in medicine, science, dentistry, what have you, there's often common myths as that entity starts to gain popularity. DSM is the acronym for dental sleep medicine. The first is, I'm a dentist, I shouldn't do this stuff. Or you're a dentist, you shouldn't be doing this stuff. I've definitely heard that in my career. I have a counter argument. You're a dentist, you absolutely should be doing this stuff. Telling that to the person telling others that they shouldn't. This is your obligation, as you will see, that you should at least be very aware to screen, and if you're not going to treat, send the patient to somebody who can treat. Another common myth, well, since I can't diagnose sleep apnea, I cannot treat it. This is incorrect, and I'm going to use a little analogy to hopefully paint this picture. If you're a pharmacist and a patient who has a diagnosis shows up with a prescription, does the pharmacist or yourself being the pharmacist in this example, do you say to yourself, well, I can't fill your prescription because I didn't provide the diagnosis? Well, that's not necessarily true. The role of the pharmacist is to provide a tool, medications, to help the doctor treat the patient from a diagnosis that the doctor gave. In the world of dental sleep medicine, we treat it the same way. We as dentists are not providing the diagnosis. We are fulfilling the prescription. Yes, we actually get a prescription from the physician that asks us to fabricate a mandibular advancement device. So you absolutely can do this, even though you're not diagnosing. Another one is Cpaps are the only acceptable treatment in the treatment of OSA. I have lots of documents that shoot this down left and right. Cpaps are great. They're still the gold standard. But I think the missing part of this particular puzzle is the fact that mandibular advancement devices are a very good second place and a very good alternative for people who can't tolerate the CPAP. So please don't let anybody tell you that CPAPs are the only way to treat sleep apnea. At the end of the day, almost 50% of patients at 5 years don't even wear their CPAP. So we need something else, and I believe we have that answer in dentistry. Another one is the at-home sleep study test don't work, HSTs. This isn't the topic of today's conversation. The home sleep study tests we're going to talk about at the end of this lecture are absolutely a critical part of how we assess the quantity of the outcome for the patients. Unfortunately, insurance companies don't pay for in-lab sleep study tests after a device is made, or at least most don't. We need another tool, and the at-home sleep study test is just that. Lastly, we've all heard it. Well, I don't make mandibular advancement devices because it changes people's bites. Where do I begin? So first and foremost, let's just do a little thought experiment. What's worse? Somebody's teeth not lining up well or being dead? Obviously, I'm trying to be a little bit, I'm trying to sensationalize this a little bit, but in reality, If we do end up with a change bite, which we can treat, we can address, we can prevent it, and we can also educate the patients so that they understand that expectation. We 100% want to understand that what we're trying to treat is way more significant than a bite not lining up well. Now, I say this as a dentist who spends the greater part of my day trying to dial in occlusions. I get it. Most of the people here are probably cringing. With that said, I would rather treat obstructive sleep apnea. If this doesn't make any sense to you, then you may not understand the fallouts of obstructive sleep apnea. Go ahead and revisit Dr. John Comisi's lecture. It's very possible that obstructive sleep apnea is in great part the reason why Americans have such a high mortality rate. Well, there's lots of resources that we can use, not only for ourselves, but for our staff and our patients. And I've placed 5 of them here. These are probably 5 of my favorites. With that said, there are more. These are tools to help bring awareness to your patients. I promise you, if you read one or all of these, I do recommend reading all of them. Although they do cover a lot of the same material, they come at it from different perspectives. If you read these, I promise you, you will 100% become a dental sleep medicine doctor to some extent. Maybe small, maybe big. You cannot unlearn what's in these books. 4 of them were written by dentists. 1 of them I know personally. 1 of them is a worldwide international speaker, actually 2 of them. And then James Nestor, he's the only non-dentist here, probably wrote the best book of them all because he's writing from a non-clinical perspective. I implore you to please go ahead and go to Amazon after this lecture and download these books or purchase them. In order to understand a concept, I always like to take a step back and look at things from a 10,000-foot view. SDB stands for sleep disordered breathing. You'll see that acronym quite regularly throughout this presentation. In order to understand sleep disordered breathing, we need to understand the anatomy that's associated with the conditions that we're looking at. So here we have a sagittal view. I think everybody knows what they're looking at, but for those that don't, let me reorient. Here's the nasal cavity, the external nasal valve of the nose. Here we have the hard palate. Here's the soft palate and the uvula. We have the tongue, lips closed, very important thing. We should breathe through our nose, not through our mouth. We all know that. But hopefully I can make the point that it's more important than we probably were taught in dental school. And then we have the oropharynx and the hypopharynx into the lungs. Here's a little nomenclature if we want to understand this a little bit more. We have the nasopharynx, which is the superior portion of the airway. The oropharynx, this green section, is where we're going to spend most of our time. This is the area that we're most likely to see problems arise. And it's also the area that we're going to treat, as we will see later. And then the hypopharynx. Well, let's take a look at sleep disordered breathing. You've been hearing me use a couple terms somewhat interchangeably: sleep apnea, sleep disordered breathing. Well, sleep disordered breathing is the umbrella term for a wide array of conditions. Let's take a look at what those are. The first one is central sleep apnea. I put this off to the side in red because this is not something we're going to treat. Central sleep apnea is treated by the neurologist or the sleep physician. I think of this as the electrical problem, whereas obstructive sleep apnea is the plumbing problem. We're plumbers, at least in this arena, plumbing dentists have you. And as plumbers, we want to understand what obstruction is so that we can treat it. So OSA, obstructive sleep apnea, is a subsidiary condition of sleep disordered breathing. We also have its cousin condition, upper airway resistance syndrome, or UARS. And then lastly, snoring, which isn't necessarily a diagnosis in and of itself, but it's a condition that lives in a continuum with OSA. So I did put that here because it's often thought of as a diagnosis. So let's go back to our sagittal view. And in order to understand what these conditions are, it's good to know where the problems arise. Again, this is a plumbing problem. Therefore, if we have a tube, we think of the tube as the airway coming in through the nose into the hypopharynx. Blockage at various levels of that tube result in different problems. Well, if we have blockage somewhere in our nasal cavity, that's most likely going to result in upper airway resistance syndrome. Think of it as obstructive sleep apnea, but higher up. But the one that we're going to talk more about today is obstructive sleep apnea and snoring, which finds its problem somewhere around this area, which is the oropharynx, which is around the level of the tongue. So another diagram here shows us, this blue line here shows us what proper airflow would look like. Again, nasal breathing is the predominant way that we should be acquiring our oxygen, except for when we're exercising. If we have restriction along this blue path, we have a problem. This is a diagram showing that the patient's asleep and the tongue is falling backwards into the oropharynx, thereby causing restriction of airflow. And as you can see, the line starts to get squiggly. This is obstructive sleep apnea and snoring. Although a little bit premature, I just wanted to, for this presentation, I did want to talk about what does a mandibular advancement device do? It pulls the jaw forward. If we pull the teeth, we pull the mandible, we pull the tongue, we open the airway. Because the tongue is attached to the mandible, anytime we move the mandible forward, we open the airway. It's a basic concept, but I thought it was worth showing that here. And that's the predominant mode of what we're going to be talking about today. Well, as we talked about in the common myths section, we shouldn't be treating these patients. I wanted to provide a workflow that hopefully allays the fears associated with this realm. For the first several years of my career, everybody was scared to do this because they thought that they weren't allowed to do it. I'm sure that still permeates through the profession, and my goal today is to dispel that. This workflow hopefully will provide some context there. So let's just say we have a patient with sleep disordered breathing. They may know it, they may not. The patient is aware and seeking an evaluation from the sleep physician. So essentially you're referring them to the sleep physician. We do that through screening and referral. A dentist can do that, a hygienist can do that, primary care physicians, and ENTs referring to the sleep physician so that they can get evaluated. Well, sometimes during the evaluation after the screening, there's no diagnosis. And I will encourage everybody not to be scared to refer somebody that you think may or may not have it. The reason being, a lot of patients that we suspect have it just don't have it yet. So if we refer them, we're bringing awareness to them so that if and when they start to get the signs and symptoms, they can have the conversation with the primary care physician or continue the conversation with us, the dental practitioners, so that they get early treatment. As we will see, early treatment is far better than late treatment. Well, what if the patient gets diagnosed? They get diagnosed with one of these conditions, sleep disordered breathing. Again, that's an umbrella term, OSA, UARS. Well, the most common mode of treatment is to send the patient home with a Cpap machine. Cpaps are great as far as effectiveness goes. Unfortunately, patients don't tolerate them well. Well, if this was the end of the story, we would have a lot of patients that remain untreated in the world of sleep disordered breathing. That's why we exist in the continuum. So this is where we play a role. Let's just say that the patient has a very well-educated sleep physician, and the sleep physician says, you know what? Why don't we try a mandibular advancement device? For one of many reasons, that's a better decision for you, the patient. They send the patient to you with a prescription, and then you fill it. At no point during this continuum did you act outside your scope of practice. This is why it works. And that's why thousands of dentists all over the country and around the world are treating patients with sleep disordered breathing. Treating, not diagnosing. Meanwhile, there's a lot of dentists out there that still think this isn't for them. Well, what about the patient that does wear the CPAP for maybe a year or two and then stops wearing it? This is probably the easiest patients for you to find in your practice because they already have a diagnosis. All you need to do is communicate with their primary care physician or their sleep physician to introduce them to the concept of a mandibular advancement device. I have some sample documents. All you need to do is download them from the Miro board, put your practice name on it, do whatever you want, send it to the doctors, and hopefully you get a prescription for a patient, and then you can fulfill it with the directions we're going to talk about today. I don't want to make it sound easy, but these are the patients that are the lowest hanging fruit because they already have the diagnosis. You can comfortably treat these patients without any sort of concern that you're acting outside your scope of practice. And that's what we're talking about here. The oral appliance is fabricated by a dentist. Now, keep in mind, I've visited the primary care physician several times over the past 2 years. I have 2 young ones at home. I haven't seen an iTero or PVS material in the primary care physician's offices. They're not taking impressions. They don't know how to do that. They don't know how to communicate with the labs. We're the only ones that can do this. So it's very important that we understand our role in this particular continuum. I did put a little insert here. The primary care doctors can prescribe these instead of the Cpap for snoring, mild OSA, and moderate OSA. They are not obliged to have the patient do the Cpap first. If it's severe apnea, sleep apnea, yes, they have to go to the Cpap first based on the literature. Then if they're intolerant, then they can try the mandibular advancement device. Or even in some cases, we do what's called combined therapy, and we combine a mandibular advancement device and a Cpap together. We reserve those for the more severe cases. So maybe you don't believe me. Maybe you guys are thinking, you know, here's this guy talking about sleep medicine. I've heard this before. You know, I've been a dentist for so long and my patients are fine. Well, the ADA produced a position statement back in 2017 that provided some context here. As I talked about earlier in the Miro board, I put that at the top because it's probably the most important document on this entire board. There's nothing earth-shattering in there. It's just giving you the green light as a general dentist to work in this arena with the confidence that you need that you're not going to be working outside your scope of practice. Now, keep in mind that the ADA is not a governing board. They're not, you know, just because the ADA says something doesn't mean we have to do it. With that said, when the ADA says something, our local boards, the state dental boards, they often adopt the ADA position statements as their rules. So it's important for you to know your particular state's rules. With that said, most states are not fighting this because they understand the value there, but it's important to know what the expectations are. And this ADA position statement will not only articulate what the expectations are, but I think it's going to allay any fears that you have going in this arena. So a few highlights from the ADA position statement. It's about 1.33 pages long. I encourage everybody to read it, but here are the highlights. One statement says, dentists are encouraged to screen patients for sleep disordered breathing as part of a comprehensive medical and dental history. I've presented this particular statement before, and I've gotten the counter arguments. Well, of course I do that because I'm a comprehensive dentist and I have everybody thinks they're comprehensive. That's fine, except for the fact that unless you're using the Epworth sleep questionnaire or the stop bang questionnaire, you are not screening patients for sleep apnea. Just because you have sleep apnea on your medical history form doesn't mean you're screening. Those are patients that already know. The ADA is saying you need to find the patients and screen the patients that don't know. So you might want to take a look at your medical history form and make sure they include some of the screening tools that we have provided in the Miro board. Another statement, oral appliance therapy is an appropriate treatment for mild and moderate sleep apnea and for severe sleep apnea when the Cpap is not tolerated by the patient. We just went over that. Again, this is coming from the ADA. And lastly, dentists are the only healthcare providers with the knowledge and expertise to provide oral appliance therapy. Or we can think of that as mandibular advancement devices. So it's a very convincing position statement that gives us the green light to move forward. But before we go on, I actually want to take a step backwards from our 10,000 foot view and maybe go to 20,000 feet. And I think you'll appreciate why I'm bringing this into the conversation. This arrow here, as we go down, is increasing patient age. And there's 3 different entities here, which will make sense in a moment. At a young age, we have the opportunity to develop the airway so that it becomes a competent airway in adulthood. So we're going to call that prevention modalities. What are the things that we can do for the newborn all the way up to maybe 10 years old in order to not treat the airway, but prevent the airway from ever having a problem in the first place? Well, we have some tools that we can employ. Phase 1 orthodontics. I'm not a huge fan of orthodontists who wait till the kid's 12 or 13. At that point, we've lost the opportunity to stimulate craniofacial growth. At that point, we're just moving teeth. We can use myofunctional therapy. Having kids chew hard foods at a very young age helps to stimulate craniofacial development. Nasal breathing and art tools. Some specific resources that help us in these modalities are a great airway-driven orthodontist. There's a lot out there. You just have to have the conversation with your orthodontist. You know, what do you think about airway? Do you do phase 1 care, interceptive orthodontics, what have you? It's also important to try to find an airway-driven ENT. Unfortunately, these are hard to find. You would think that all ENTs are airway-driven, but many, unfortunately, don't understand the intricacies of modern treatment of the airway in their own profession. If you read their literature, you'll get a very good sense of how early they are in the understanding of what airways are supposed to be. Myofunctional training through groups like AHS and then the books that we talked about earlier. Well, maybe we missed the boat. The child is now 11 or 12, and now we have to adopt treatment modalities. Ortho, a crowded patient that is 12 or 13 is a treatment. That's not a prevention. The reason they're crowded is because their head and neck didn't develop. So we can do phase 2 orthodontics, palate expansion, surgery, myofunctional therapy, and nasal breathing. And again, there's some tools that we can employ to do that. Well, let's just say the individual made it to adulthood. Unfortunately, whether they had ortho or not, they still have an inadequate airway. That's where we step in. We can use surgery. We can consult with the oral surgeons to do surgical palate expansion, orthognathic surgery, aggressive orthodontics, and then sleep apnea therapy is like the Cpap and the oral appliances, which is what we're talking about today. And there's all kinds of resources that you can look at to learn more about this. Happy to share if anybody wants to dive more into what the alternatives to the mandibular advancement device might be. But as we can see here, we're focusing today on this. So we're at 20,000 feet, we're looking down and we see that yellow area there. That's where we're focusing. But the reality of it is, decades before that patient had the need for a mandibular advancement device, they had the opportunity to have their skeletal structure grow properly so that their airway developed properly. As you read those 5 books, you're going to get a really good understanding of how far behind medicine and dentistry are in the world of understanding how much we're missing the boat. Hundreds of years ago, we didn't have that problem. Today we do. And if you read those books, you'll get an understanding of why that is. It's super interesting. All right, so you've made the point, but where do I start? Well, there's 2 major approaches we can take. I like to break these into 2 different categories. One is the all-in approach and the other is the basic approach. The all-in approach is the kind of dentist that says, I don't like dentistry anymore, but that's my degree, so what can I do? I get a magazine from Dental Town or some flyer that comes in that says, you can do $3 million in production if you become a dental sleep medicine practitioner. Well, that targets the tired dentist, somebody who's looking for a change. Maybe we could think of this as the dentist that's not good with their hands and they've, just realized that they're not gifted in that arena and they want to do something else. Dental sleep medicine doesn't really rely on hand skills as much as restorative dentistry does. So there is a segment of our profession that may look at the all-in approach. Well, there's also the medical dentist or the wellness dentist. This is the person that loves working with their medical colleagues. Maybe they didn't get into medical school, so they became dentists, but they want to be as close to medicine as they can. Dental sleep medicine does provide that opportunity. And then lastly, the large dental practice. This is where our practice fits. We're able to do this in a somewhat all-in approach because we have more resources and providers to focus our energy in this arena without taking away from the needs of a restorative dental practice. But what about the everyday GP? You're right out of school, 3 years. Dr. Roy makes a really good point that I should know this stuff. Well, I'm just going to go all in. I'm going to learn everything I can. I'm going to buy all the books. I'm here to tell you, don't do that. I might take a little bit of flack from some people in the audience that have done this. Great for you. I would recommend a different approach. So maybe you just want to help your existing patients. You're not looking to work with sleep centers, and you're not looking to do any more than just help the patients that already live within your four walls. Well, we have an easy button for you. Unfortunately, as we all know, in medicine and dentistry, there's no such thing as an easy button. So I'm going to use the easier button. And hopefully that easier button is what we call the basic approach. And fortunately for all of us in the audience, this is an approach that the everyday GP can do. And I'm not trying to tell everybody that they're everyday GPs. I'm just saying this is an approach, if you are one, that you can employ as early as tomorrow. All right, so this is the first segment of the Miro chart. So what I want to do, I'm still sharing my screen. I'm going to switch over to the Miro chart. Of course, this is in my way. All right. So I know some of the print is small, but I'm going to start from a little farther out. And this is the starting point right here. Again, this is just a brain dump for me, but I organize it in a way to hopefully make a point today. Well, if we zero in, and you're somebody that wants to help your patients live a higher quality of life, you can watch this PowerPoint presentation. I have a copy of this presentation on YouTube. It's somewhat similar to what I talked about tonight. We have the ADA policy statement, common myths about oral appliance therapy, and then one of the more important ones, how do I get started in DSM? I would recommend you start there so you can get a sense of where to go. Well, we talked about a few different approaches. Just for fun, I added a moderate approach, but here's our basic approach, moderate, and the all-in approach. The way I like to think about this, you really shouldn't do the all-in approach unless you have patients coming your way. Well, if you haven't started doing this, you haven't developed the skills necessary to go down that road. So as you will see under the approaches, there's a number of cases per month. This just gives you some idea, based on the number of cases that you might already be doing, whether or not you should go down these different avenues. Let me start with the all-in approach. Again, this might be better suited for a dentist that's looking for a career change but wants to stay within the profession. That particular person is going to have a hard time building the network necessary in order to get the patient volume needed in order to become a dental sleep medicine only dentist. With that said, it can be done. I'm hopefully going to articulate a way for you to work your way there, but not necessarily dive all in. Well, if you're going to do this, you really should initiate an education process. And the one I recommend is the AADSM, the American Academy of Dental Sleep Medicine. They have more resources than any other agency out there for dental sleep medicine. But they have a series called the Mastery Series. And in my years of taking CE, there are few continuums that come close to the quality of the content of this particular series. They have ENTs, oral surgeons, anatomists. I mean, it's unbelievably thorough in the world of dental sleep medicine. After you sit for that, and that takes about 2 years to do. Fortunately, since COVID, it's online, at least it was for me. I would jump on it if they decide to bring that back to live, because it's way easier to do it online because there's a lot of stuff to watch. After you do that, you can sit for your diplomacy in the American Board of Dental Sleep Medicine. This is more the quote unquote specialty. I have to be careful using that term. But essentially, this is the credential that you may need in order to open up a dental sleep medicine center. I say that you don't need it, but I wouldn't open one up unless I had the credentials that were greater than everybody else in my community doing the same thing. Now, let's just say you do that and you love what you do, then you can move on to the Olmos curricula. Dr. Stephen Olmos, we're going to see a little bit of him later. He took the world of dental sleep medicine and combined it with TMD. Probably one of the more brilliant minds in dentistry. He put together some of the most amazing out of left field content you're ever going to see within the profession. And it's absolutely amazing. And if you decide to do that, you can then treat your patients for both TMD and sleep. And what's amazing is those two conditions actually superimpose on each other quite a bit. When you're treating one, you're often treating the other. With that said, this is quite a long approach. I put an estimated time frame of 3 to 7 years. even for the aggressive CE junkie dentist. Well, what if you just want to take the moderate approach? You get a flyer in your periodical that comes in the mail, and it says Sleep Group Solutions has a seminar in Boston and would love to invite you. So you go to the seminar and they have somebody on, up there talking about how amazing dental sleep medicine is, which I agree. The problem is it's a significant investment. Sleep Group Solutions basically takes all of the equipment, all of the procedures and the support and gives it to you. It's an absolutely amazing company, but it's costly. So if you do this and you realize that your practice doesn't have the number of cases required to support that investment, then you lost your money. And I have 2 friends just in the state of Maine within the past 2 years that did this, despite my recommendation not to. They went to the conference, they drank the Kool-Aid, and they're now sitting with a very expensive pharyngometer that they rarely, if ever, use. This investment is on the order of $30,000 to $50,000. At least that's what it cost for us. Glad I did it, but we did it at the right time. We had started doing cases prior to that. Great avenue. Click on this link here if you want to learn more about it. I would say start with the basic approach and then wait a couple of years before you go to one of the seminars. All right, what about the basic approach? So this is kind of the meat and potatoes of the presentation. We're doing this on the Miro board. I'm going to walk you through kind of a decision tree for you to use with a patient tomorrow. All right, patient comes in. You identify the patient as having high risk for sleep apnea, or let's just say they have sleep apnea. And you want to learn more about their condition, or you maybe want to treat them. Well, there's 2 kinds of patients. One, there's a Cpap non-compliant patient or a Cpap intolerant patient. And then there's a patient that doesn't yet know they have sleep apnea that is high risk for that condition. Well, let's start with this patient over here. Low-hanging fruit, Cpap non-compliant patient. They've already been diagnosed. They just don't want to wear their Cpap. Well, you have 2 options. You can come down this way, do the case in-house, or if you have somebody in your local dental community that already does this stuff, you can refer to a dental sleep medicine dentist. There's a letter here. If you click on it, it's basically a template that says, hey doc, I'm referring the patient over to you. Please return the patient for restorative and preventative maintenance. In order to educate the patient, it's always important to educate our patients about what's going on. We have something at Cade we call the pie sheet or patient information essay. We do these because we believe that when we tell patients things, it's not that we believe, this is a fact, and I think everybody will agree. When you're sitting chairside and you tell a patient something, they're going to remember 20% of what you said. I like them to leave with something physical so I can say, well, I gave you that document. That's not what it said there. So you have something to fall back on. When you're sending a patient for something like this to another dentist, it's important to kind of share with them what you're doing, why you're doing it, and what your role is in this particular referral. So that's available to you if you would like. But instead, you decide to do the case in-house. You say, you know what, I want to learn more about this. So I'm going to treat the patient. Well, the first thing you should do is make sure their TMJ is in good condition. Although, like I just said, Stephen Olmos talks a lot about the fact that TMD and the airway are, TMD and sleep disorder breathing are often treated the same way. For your first case, I would say, yeah, let's refer that one out. You should have a tool. The Tmd screening tool that we have through Cade, you can click on. It's a very, very easy step-by-step way of saying, does this patient have TMD conditions that I might want to avoid treating this patient for? So you have that printed out in your operatory. Let's say the patient's fine. All right, you then send the letter to the primary care physician. Let's just take a look at it. This is Cade template letter A, letter to the primary care physician for the Cpap intolerant patient. Basically what this says is, hey, sleep physician, your patient doesn't like the Cpap. You may or may not be aware of mandibular advancement devices and oral appliance therapy. If you're unaware, here are some resources if you would like to educate yourself more. Please provide a prescription, and here's a sample prescription for them to write to you so that you can then execute it. We're trying to make this as easy as possible. It's things like this that often prevent everyday clinicians that are busy doing hygiene exams and restoring teeth all day long. It's things like this that normally get in the way. We've made that all available for you. So you send that to the primary care physician with the hope that we obtain a prescription. You can encourage the primary care physician or the sleep physician. Some primary care physicians decide to do that. If you decide to do the case in-house, there's a pie sheet that you would send the patient home with. Again, pie sheet is a patient information essay. That's the easiest patients you're going to find, and that's what I'd recommend you start looking for tomorrow. If you don't have sleep apnea and or CPAP use on your medical history form, I would encourage you to do it, or encourage your hygienist to have these conversations with all of the patients that come in that may or may not fit into the category of being at high risk. Well, what about undiagnosed high-risk patients? Your hygienist and yourself are going to start to learn what these patients look like. Over time, you can see them from a mile away. But until then, and even so, we need some screening tools that we can use that will give us some confidence based upon science that will help us understand who these patients are. I provided 3 here. The Epworth sleep questionnaire is the traditional tool. It's a little bit antiquated in its science. With that said, it's a tool that's still used in primary care offices. So it is there for your use. The Stop Bang, I think, is the more updated version of that. Stop Bang is an acronym that you can use with your patients to hopefully get a sense, are they at high risk? And then clinical signs and symptoms, this is something we put together. It's basically just an aggregation of different signs and symptoms that we can see inside the mouth. Scalloped tongue. The list goes on and on. Narrow arches, high palatal vaults, bimaxillary premolar extraction. So click on that. Those are some things that will give you some awareness. Okay, this patient might be at higher risk for sleep apnea. Well, you go through these, whichever one you decide to use, and you determine that this patient has, you're not diagnosing yet or at all, you've determined that they're at high risk for sleep disordered breathing. So you have 2 options. You can do the case in-house, which will require a prescription from the physician, or you send it to the dental sleep medicine in your town and have them do it. And then you provide the patient with the pie sheet so that they know what's going on. So you do the case in-house, give the patient this pie sheet, you do your TMD screening just like before. You want to make sure that there's no intercapsular issues. If you click on this, it explains it in great detail. You then send the letter to the primary care physician saying, hey doc, I think this patient might have something. Sorry, I'm just a lowly dentist, but I hope maybe you take the time to send this patient to a sleep center, and voila, all of a sudden they have sleep disordered breathing. Eventually, 10 months later, at the rate that most medical facilities work these days, you get your prescription. I would encourage you to write down the patients that you send these pie sheets to. What we do when we send out a pie sheet, we just write their name down. If we don't hear back from them over a month or 2, we just remind the patient, say, hey, have you talked to your physician? You know, we try to be an active member in making sure that we advocate for them, not just hand them a referral. All right. Well, here's the meat and the potatoes. I'm pretty sure that everybody thought that we were going to start here today. Initiate OAT treatment. Well, there's lots of lectures that talk about that. To me, the hard part is getting to this point. Yes, you can go take all kinds of curricula out there, but to me, I wanted to provide something that you could use tomorrow, and hopefully this is powerful enough that you feel comfortable doing so. So these 3 blue squares are actually in the PowerPoint, so I'm going to switch back over to that. I apologize about the sniffling. I'm in my basement. Apparently, I'm allergic to something down here. All right. Oral appliance therapy, we used the term umbrella term earlier, talking about sleep disorder breathing and then the subsidiary components to that. Oral appliances is a umbrella term. We have mandibular advancement devices, which is the bulk of our talk today. We have tools like the Avio TSD, which is a tongue displacement device, and there's other tongue displacement devices we can use. And although they're not oral appliances, if we improve nasal breathing through one of many different tools, I actually have the mute right here that I had in my nose while I was talking, but unfortunately I was sniffling too much. Nasal breathing improvement can improve airway. Let's revisit this because this is the most important slide of it all. Again, I'm not trying to demean the knowledge of the audience that's here, but I want to make sure that everybody understands what's going on. First and foremost, we shouldn't be breathing through our mouth. Everybody should be breathing through their nose under most conditions. Unfortunately, if the tongue relaxes, or if we've had too many drinks that night, even one glass of wine can cause relaxation of the pharyngeal muscles, causing collapse of the airway, which is why people who don't have sleep apnea often say they snore more when they have a glass of wine. This is why. And what that does, it causes restricted airflow. It's the slapping of these tissues right here that causes snoring. I like to think of it as two rubber dams. If you had two rubber dams together and you were able to blow some concentrated air between them, they would vibrate, and the rubber dams slapping against each other would produce a sound of snoring. Sleep apnea is when that obstruction is so bad that there's no airflow. Well, fortunately, the mandibular advancement device can help us. We went over this earlier, so I'm not going to belabor the point. What is the timeline of mandibular advancement device therapy? Well, after you've identified the patient and you have the prescription, you then start with the records. Although obvious, you have to make sure that the patient's dentistry is completed. You're not putting these appliances on an active perio patient or a patient with decay. You then need to obtain an upper and lower PVS or the impression of your choice, impression or a digital scan. If you work with Diamond Orthotic Lab and several other labs, it's very important to capture the hamular notch. For those of you who don't do removable dentistry because you don't like capturing the hamular notch, sorry, you need to capture the hamular notch here. It's an anatomical landmark that's very important in fabrication of a mandibular advancement device with labs that understand how to do it well. Well, then you also need a Byte registration, also known as jaw relations. This is probably the trickiest, no, not probably, this is the most difficult part and tricky part of the entire world of dental sleep medicine. If you go with Diamond Orthotic Labs, ask for the ONP appliance. Again, in the mural board, there's directions on all of this in much more detail. The ONP is a mandibular advancement device, but it was developed by Dr. Stephen Olmos, and the O stands for his name Olmos, N for nighttime, and P for positioner. So his appliance is the ONP. He also has a daytime appliance, which is the ODP, which is essentially a TMD appliance worn during the day for patients that have severe TMD. Well, there's different methods to capturing the bite. Early in the days of dental sleep medicine, clinicians were using just an arbitrary protrusive bite. They were just having the patient slide their jaw forward, and they just knew if you slide the jaw forward, the airway improves. Why don't we just take a moment and do that? This is a very valuable exercise that we can do together, and then you can do this with your patient. Go ahead and bite your teeth into MIP, close your eyes, and then breathe through your nose and try to feel the air as it's going through your nasal cavity. And do that 3 times. This gives me a chance to drink some water. Now keep your eyes closed, but then jet your jaw forward in a protrusive manner, not too far, just pass edge to edge. Now breathe through your nose. Now you should notice an increase in airflow. This doesn't work with everybody. This works in people who have a very restricted or obstructed air passage. But this is a tool that you can help show your patients that you can increase airflow by moving the mandible. Well, somebody came along in the mid-'80s. Not sure if his name is Dr. George, maybe his first name was George, but he created what was called the George Gage, which was a slightly more advanced version of the protrusive bite. We're going to talk a little bit more about that in a moment. In the world of neuromuscular dentistry, they used a neuromuscular bite to find the position for the mandibular advancement device. The tool, the pharyngometer, we do use in our practice. This is the tool that Dr. Kamisi talked about. He also used this tool in that study that he published in the Journal of General Dentistry. The problem is it's an expensive piece of equipment, and it's not something that I would really recommend the everyday dentist go out and buy. until you decide that this is something you're going to do on a regular basis. So over the past several months, I've been trying to think of a way how to help dentists enter this world. And it just happened to be that I started to take Stephen Olmos's lectures, and he produced what's called, or he introduced to me what's called the Phonetic Bite. This is free, or more or less free, and it's something I'm going to be sharing with you today. But back to the George gauge. This is important for you to understand because 90 to 95% of courses you're going to take are going to use something like this. Again, this is a protrusive bite where the mandible is moved forward. The directions for this particular gauge is the following. Please have the patient maximally protrude the jaw. Now, I don't know if you've done that before, but it's not very comfortable in the TMJ joints. So you have the patient do that, you measure, and then you say 60% of that measurement is their treatment position. Now, what's interesting is that has nothing to do with the airway. So we definitely have to have some other tool that maybe listens to the body or listens to the airway so that we get a proper mandibular position in relation to this protrusive bite. The other thing that this bite doesn't do, which Dr. Comissi did a great job of elucidating in his study, I wouldn't say that he was the first one to discover it. I think he's just one of the early people to publish on it. It's been known anecdotally for years that the opening of the mandible actually produces a better airway more than the protrusive dimension. We talked about that earlier. Therefore, the protrusive bite only gives you one dimension, and it happens to be the least important dimension. Where do we like the mandible to end up? The phonetic bite is going to help us determine what that is. Again, I have step-by-step details on the Miro board. Just click on the rectangle that says phonetic bite. Again, what is the goal of the phonetic bite? I mean, what's the goal of any bite that we take? Whether it's centric relation, MIP, centric occlusion, what have you, what we're trying to do is capture a three-dimensional position of the mandible in relation to the maxilla that best serves positive airflow. In this case, if you're doing a full mouth rehab, you could say that best serves the aesthetics or the dental occlusion or what have you. But in this case, we want to best serve positive airflow so that we can treat sleep disordered breathing. Again, the phonetic bite is important because when we speak, we have a coordination between the pharyngeal muscles of our airway and the muscles of mastication, which they're not only there for masticating, they're there to control the mandible. Those two muscle sets work in coordination to produce speech. Well, if you're speaking, where your mandible ends up during speech is a neuromuscularly balanced position. It's a good spot. It's a happy spot. And the cool thing about phonetic bites is there's actually an infinite number of locations that we can choose, unlike centric relation where we're all sweating. You know, did we get, you know, the condyle seated in that nebulous place that nobody can agree on? The phonetic bite is much more free. It's much more, there's a lot more room for error, I guess is what I'm trying to say. Not room for error. There's more options to get it right. So the take home message about the phonetic bite, if we're going to treat the airway, why not find a mandibular position in relation to the maxilla that is most positively influenced by, wait for it, by the airway. We're asking the body to tell us where the mandible wants to go. That just happens to be where the parapharyngeal muscles have the most airflow, which decreases the likelihood that we're going to snore and have sleep apnea at night. That's the concept of the phonetic bite. It's also very good for TMD. Topic for another day. So here's Dr. Stephen Olmos. This video is available on YouTube. Actually, the older videos that he has are available on YouTube. You can find this video on Diamond Orthodontic Labs website. It's a series of videos. I'm going to play the important part for you here.
Speaking space does not allow, and that would be optimal. However, that varies person to person. And as a result, if the minimum speaking space does not allow for here as opposed to acrylic versions here. So these all have different dimensions, and whether you're making appliances for sleep or whether you're making appliances for chronic pain, all of those dimensions need to correlate with the space that you're capturing. All right, so just count from 66 to 77.
66.
Now in this video, he doesn't do a very good job articulating what you're looking for. In the literature that he's produced, he does talk about it. What he's looking for is any position that the mandible is in while the patient's speaking. If we are doing a full mouth rehab or we're doing a denture, maybe we want the S sound, which is where she's at this particular moment. It's close to edge, maybe 0.5 millimeter of overjet. But if we're trying to create a large mandibular advancement device, we need the mouth more open. So we want to try to capture the position when they're more open, which correlates to maybe the word 69. So when they say 9, their mandible at maximum opening is a position that we can select. Again, there's an infinite number of positions within the range. Again here, it's not an exact position. It's a coordination between the muscles of mastication and the parapharyngeal muscles of the airway. As long as those two things are in harmony, it doesn't matter where we go, which is crazy because in dental school we were taught, don't change the bite, don't open the vertical. For those of you who have taken advanced CE, maybe with Spirit Cois, we now know that, that's really not a thing. If you change the vertical in a patient that has an airway problem or a TMD problem, sure, they're going to get worse. But we now know how to address that. So again, as you see what he's doing, he's selecting one of many different positions.
67, 68, 69, 70, 71, 72, 73, 74, 75.
I'd like to demonstrate the technique. It's important, as I said, to try to capture this in a comfortable mode and to make sure that the patient's comfortable with the device before actually taking the bite registration. If you bring something towards somebody and they're not ready for it, they're not familiar with it, then they're going to back away. So I always try to keep the device out.
The device that he has in his hand, I believe he developed. I have not used it. We use saliva ejectors. You just have to find a round object. The reason it has to be round, it has to roll so that the muscles don't get imbalanced. I think we can deduce why that is. So if it's not round, it's not going to give you an accurate result. But a cotton tip applicator, what have you, when you want to use it on the incisal edges, not in the embrasures, again, this is all in the step-by-step manual on the Miro board. But you're going to see him using his device here. Just know that you can use different instruments already located in your office. I don't know how much this device is, but I'd imagine he probably charges a fair fee for it.
Out of sight until the last little bit of placement, okay? So we'll go ahead and ask the person to count from 66 to 77, but we're gonna ask you to think about something that you like to do for vacation. So what's your favorite thing to do for vacation?
Go to the beach.
Okay, so you're on the beach. What do you like to do at the beach?
Just
Lay in the sand. Okay, so you're laying on the sand. It's a beautiful day. You're looking at the waves. That's what I want you to think about as you count from 66 to 77. Okay, so can you go ahead and do that for me? And go ahead and count.
66, 67, 68, 69, 70, 71, 72, 73, 74, 75.
Okay, so what we're looking at is how much space we need. So these start out at an increment of 1 millimeter. The first one is 2 millimeters, then 3 millimeters, 4, 5, all the way up to 10 millimeters.
Again, the dimensions is not important. It's the fact that you are capturing a three-dimensional position that corresponds to a mandibular position that corresponds to her speech.
Some of your patients may have an open bite. You may need to use the larger range. The little diamond in the middle is just for holding the device, because we need to make a transfer here with your assistant. Don't try doing this with just by yourself, because you won't be able to stabilize this and the jaw can move. So we can see that she needed, for minimum speaking space, probably 3 millimeters would be ideal. So we just simply break this off here, and we'll go in and check it. Can we have you rest your teeth on there for us? And now what you need to do is look back here and see if you have enough room.
Now he's talking about using this for TMD and for sleep. In the world of dental sleep medicine, you actually want to have the patient open enough to get about 4 to 5 millimeters in the posterior. The reason for that is mandibular advancement devices have an upper and lower arch coverage. So there's a lot of material that needs to exist interocclusally, so you need to have enough space. So you're going to have them open quite a bit. In the step-by-step manual that we have on the Miro board, it goes over some different ways of how to measure that while you're doing this.
But I can see that there's only maybe a 1/4 millimeter space between those teeth. And that's ideal for her, but it wouldn't be ideal to make a day appliance. So I need another millimeter, so I'll just take that off and we'll try that again. Can I have you rest on that, please? So even though you're capturing the front, you have to be looking at the back to see if you have enough room. And that's about as thin as I could possibly get for this Byte registration. So I'm making a day appliance, I'm making a night appliance. So this is my minimum. So this is what I would make the day appliance to. And then I would tell the laboratory.
Just for clarification, again, the day appliance is what he's using to treat this patient's TMD. This is not the objective of today's lecture, but just so you understand what he's trying to do, he's going to make a lower orthotic made out of nylon, super low profile, that the patient can wear, they can speak, they can chew. Your TMD patients that wear those big bulky appliances that we're used to making that look like night guards all day long, that's a thing of the past. What he can do with this particular technique is treat those patients. Again, that's a topic for another day. I just wanted to make sure you guys understood what he was trying to do.
To add a millimeter to this in order to have enough vertical to make a nighttime device. And in this patient's case, I'd be making an ONP. So I'm going to need a little more vertical to produce that with an anterior disclusion and the ring on there. Okay, so we'll demonstrate. So I'm just going to ask you to count, and somewhere along the way, I'm going to say stop. And then I just want you to freeze in that position. I'll demonstrate it for you, okay? 66, 67, 68, stop. See how I froze? Okay. Then I'm going to put this on top of your tooth and you rest on it just as you did, and then just don't move after that. Okay. That's how we're going to do this. Okay. So let me do that. There we go. So your assistant will be holding the syringe for you, and then you go to place it, and then we're going to make the exchange so that we can keep this mandible in exactly the 3-dimensional correction that the speech is producing. So can you do that for me? You're at the beach, remember, and you're thinking about the beach. Okay, so 66.
66, 67, 68.
Stop. Okay, we'll try that one more time. That was pretty good, but you just kind of moved a little bit there. But okay, back to the beach. Okay, go ahead.
66, 67, 68.
Stop. And then just rest on it. That's perfect. If you can hold that just like that without moving, okay, and it's very critical that the assistant holds that. And very often your patient's tongue is going to be in the way, so you ask them to please move their tongue.
When doing this, I would recommend trying to come more from an anterior perspective. As you can see, when we pull on the buccal, when we pull on the cheek, we run the risk of activating the muscles of mastication. I'm surprised that he's doing it this way. With that said, he's probably doing it for the video just to show you. Come in from a more anterior posterior direction.
But not their jaw, so that you can get the material, and be sure that the material flows all the way through, so you can be sure that you have a good Byte registration. And now this takes about 20 seconds using the best Byte material produced from diamond.
So he's definitely trying to sell a product that he manufactures. With that said, you want to find the right Byte material. Just talk with the lab that you choose to make sure you're selecting something that works for their needs. All right, so at that point, we sent everything off to the lab. We had the upper lower impressions and we have the 3-dimensional bite record, which again is the hardest part of this whole continuum. The reason why I showed the phonetic bite, although it's maybe an entirely new concept, it's easy and it's cheap. And I also think it treats TMD very well, in addition to dental sleep or sleep disordered breathing. All right, so the appliance comes back and you're going to deliver this. You're going to check for comfort. You're going to teach the patient how to place and remove. You're going to assess for TMJ tension. If you use the George gauge, this is relevant. If you use the phonetic bite, it's irrelevant. Reason being, when we speak, our mandible isn't far forward and it doesn't put stress on the joint. You're also going to educate the patient on bilateral imbalance. So when you put this appliance in, the appliance was made based on where the mandible was in a very happy place. Well, we know that teeth are often erupt in an unhappy place, and it's the origin of a lot of problems. Therefore, when you first put this in, it's likely that the patient's going to feel like they're hitting one side, not the other. You don't adjust it. That's actually going to tell you the bigger the discrepancy from left to right actually gives you a pretty good idea of how much you're going to be helping the patient. If a couple of weeks go by and there's something that is in the way, or there's an interference to maximum, not intercuspal position, but the flat surface is coming together, maybe you adjust a little bit, but you're not trying to grind it early on. Then there are what are called titration appointments or follow-up appointments. The George gauge, as we talked about, is a position that's selected based upon God knows what. My guess is they just took a bunch of patients and found the sweet spot to be 60%. Again, that's only in the horizontal direction. But as time goes on, based upon the patient's subjective symptoms, again, how they feel, whether their spouse is saying they snore or not, that's going to be the information that they provide you to make adjustments. That's not how I'd want to practice dentistry. That reminds me of, putting a denture in and then having the patient come back every other day to do an adjustment with PIP paste. There's also something called the Seattle Protocol. In the spear world, they have an airway prosthodontist. His name is Jeff Rausch, I believe his name is. And he came up with this protocol, which is rather impressive. It's quite laborious. It requires a lot of different steps. You're basically having the patient come back a billion different times, and you're asking them how they're feeling and, what are the subjective symptoms. If you're charging $7,000 for a mandibular advancement device, I guess you can do that. What's pretty nice about the phonetic bite, we don't worry about any of this. The phonetic bite gets us where the patient needs to be right out of the gates. Again, the goal is to have 0 adjustments. That's what the pharyngometer, again, that's an expensive piece of equipment that you may find in your practice one day, or the phonetic bite. In our practice at some point in the near future, we're actually going to do a study where we compare the pharyngometer to the phonetic bite to see how those two positions line up with each other. My gut instinct is telling me that it's probably very close. So once the patient has been wearing this for a period of time, we do about 3 months, we want to do what's called an outcome assessment. We can't objectively test the patient in a sleep center. So we have to send the patient back to the primary care physician, which serves a couple purposes. One, we want to show the primary care physician that we're capable of helping their patients. The same with the sleep physician. But we also want to try to get them to hopefully have a sleep study done so that we can quantify objectively the outcome of the treatment. Most of the time it's much better, but not everybody can be treated by a mandibular advancement device, which is an advanced concept that we can dive into at a later point in time. Be happy to talk to anybody about what that means. Long story short, not everybody can be treated with a mandibular advancement device, no different than certain medications don't work on certain people. That doesn't mean we don't use them. Now, in our practice, we made the investment to have home sleep study tests available for our patients. So we send these home with our patients after the 3-month period of time so that we can get objective data, more for us to know. We're not doing anything with that. We're not diagnosing. We're not doing anything that's going to hurt the patient. We're just trying to get them quantifiable data so that they know the improvement of their health as a result of the mandibular advancement device. Although somewhat of an aside, how do we broach this subject with patients? We've all done it. Ask a patient, do you snore? Do you have sleep apnea? Or how about this one? Has anyone ever made a comment about your sleep quality? I'm just going to say that these two sometimes upset patients. And we found this bottom way of addressing it with patients to be very helpful in gathering information. When you say, do you have something, you're being very specific. When you're more broad, like the bottom comment, you're not only being non-abrasive, but you're also leaving the door open for some obscure thing that might provide some information that's helpful for you. So use this as you want. We found this to be a game changer in our practice. How about some patients? Talked a lot about helping people. What have we done in the past? So Chuck B, several years ago, he was one of the early patients when I was really kind of getting my chops in dental sleep medicine. So Chuck was a 65-year-old male that presented for a recall exam. He presented with severe scalloping of his tongue. Once you see a scalloped tongue, you're going to see a million scalloped tongues. It's kind of like when you buy a blue truck. Everybody has a blue truck, where you realize, you kind of realize that they're everywhere. This patient also had type 2 diabetes, hypertension, and high cholesterol. This is the poster child for sleep apnea. It's the person we think of when we think of it. So the hygienist had inquired about his sleep quality. The hygienist said, Chuck, has anyone ever made a comment about your sleep quality? Chuck says, yes, I have sleep apnea, but I hate my Cpap. I'll be honest, back then we didn't have a comprehensive medical history like we have today, so we didn't necessarily have these questions. Luckily, my hygienist was astute enough to ask him this question. Now, fortunately, she kind of set me up. So when I came in the room, the patient was ready to talk. She said, would you be okay discussing some ways to help your sleep apnea with Dr. Roy? Patients have no idea what we are capable of as dentists. It helps to have the hygienist set the stage for us so that when we come in, we don't necessarily come out of left field. So Chuck complied. So I said to Chuck something to the effect of, Chuck, we have a process that many patients just like you have found extremely valuable. With the help of your primary care physician or your sleep doc, we may be able to get you some treatment without a Cpap. Is a better quality of life something you'd be interested in? Chuck says, sign me up as long as it doesn't involve that big machine. He said something to that effect. So we sent one of the letters that you find on the mirror board to Chuck's sleep physician, and we received back a prescription for an oral appliance. So Chuck shows up several weeks later. We used a Phonetic Bite to obtain his ideal three-dimensional position for his records. We send it to Diamond Orthotic Lab. We deliver the appliance and we follow up at weeks 1, 4, and 24 and every year thereafter. It is part of our expectation that we do follow these patients on an annual basis. So here was Chuck's outcome. This is kind of his report card. You can think AHI is an acronym for Apnea Hypopnea Index. It's essentially how many times per hour the patient has a disruption in breathing or desaturation in oxygen. Just think of them as bad events while you sleep. It's more complex than that, but for the purposes of today, think of that number as a perio pocket. A 55 is like an 8mm pocket. Well, he did have a post-op sleep study done with his Cpap. His Cpap was rather effective. In medicine, there's something called the maximum medical improvement, or MMI. MMI is not a term I think we use in dentistry, because in dentistry, we're often trying to do things to perfection. Our craft is a little bit different. We're trying to get the shade perfect. We're trying to get that marginal ridge perfect, the contacts, what have you. In medicine, they quantify things more on, quality of life improvement. Chuck's quality of life was drastically improved with the Cpap. He just couldn't tolerate it. So his maximum medical improvement was substantial. His sleep apnea didn't go away. It just improved substantially. With his sleep appliance, it went down to a 17. Again, not as good as a Cpap, very good, but much, much better than not having anything at all. And to provide some context, here's a graph that we made on the advancing OSA disease severity based upon the number of apnea, hypopnea events per hour. Under 4 or under 5 is normal, 5 to 15 is mild, so on and so forth. So as you can see, he went from very severe all the way down to almost mild. Then there's Susie S. Susie S is not your poster child for sleep apnea. She's a female, she's 54, she's a nurse, no significant medical history. She has an athletic build. She was probably 115 pounds soaking wet. She exercised regularly. She's the kind of person that you would expect to be the most healthy person in the room. Now, what was very interesting, she worked at a sleep center. She's a nurse in medicine, working at a sleep center with 3 sleep docs. She'd been there for over 10 years, and she didn't know what she had. During an examination, she showed several signs of sleep disordered breathing, presumably the cousin diagnosis of sleep apnea, upper airway resistance syndrome. So we encouraged the patient to get a sleep study based upon what we saw in her mouth, and lo and behold, she had that condition. The primary care, actually the sleep physician, prescribed a mandibular advancement device and referred her to the ENT. Again, upper airway resistance syndrome often involves the ENT because they have to somehow clean out the nose or improve the airway within the nose or the nasal passage. In this case, both forms of treatment were required for her, and she went from a quality of life somewhere on the order of a 4 out of a 10 to an 8 out of a 10. Now, what's amazing is this conversation started in a dental practice. So if you don't think we have a role to play here, then I don't know what I can do to convince you. But I think the case is that we understand that this is relevant. Her AHI was only an 8 to start with, and it went down to a 2. Patients with UARS don't necessarily have high AHI numbers, but they have very bad sleep. And then lastly, Peter I. Peter I is the guy that shows up. He's a 25-year-old male. The reason I wanted to include Peter here, we talked about that continuum where we often earlier in life have the opportunity to intervene and hinder the progression towards disease. Unfortunately, the medical model is set up so that we often find out about sleep apnea in patients once the disease is at the severe level. The reason for that is the sleep physicians are using the Epworth Sleep Questionnaire, which asks questions like, do you fall asleep while sitting at a stoplight? Well, yeah, I mean, if that happens, you can imagine they have something wrong with them. Well, what about the guy who would fall asleep at a stoplight 20 years from now? Where is he now? And that's Peter. We don't want to wait till the disease is so severe that we've missed the boat, not only to treat at a younger age, but also maybe hinder the disease progression as they age. So Peter reports the guy that everyone makes fun of when he snores. He goes on camping trips and everybody makes fun of him because he's the one chopping wood all night long. He's an endomorph. Anybody with an 18-inch neck or greater is at higher risk for sleep apnea. The bigger the neck, the more soft tissue, the smaller the airway. He's a Mallampati class 4. That's an airway size assessment tool used by anesthesiologists. He reports that he's tired during the day, especially after a night of drinking alcohol. We talked about that earlier. Alcohol is a muscle relaxant. We have muscles around our airway, so if they relax, the airway collapses or has a higher chance for collapse. So we did our protocol, sent Peter to the sleep physician. He comes back with mild sleep apnea. His AHI is only 13, still sleep apnea, not diminishing it, but compared to the other patient at 55, this is rather mild. But at AHI of 13, he still needs a Cpap, or at least that's the conventional model. But due to his age, he's uninterested in a Cpap for obvious reasons. So his astute primary care physician prescribes him an oral appliance. I say astute because this primary care physician was educated by our practice. There's all kinds of different ways of doing that, lunch and learns, letters, meeting with them in person, what have you. Once you start building a network of medical providers, you will get referrals from them. There's no better feather in your cap than getting a referral from a physician. So then we make his appliance. More importantly, he now knows that he has a condition that can be modified by his habits. So his drinking and his potential obesity are contributing factors significantly to his sleep apnea. And if he doesn't change the trajectory of his disease, he's likely to have a CPAP. It's this level of thinking that Western medicine is not set up for. This is an Eastern medicine perspective. Try to treat the disease before it ever becomes a problem. In this case, we're kind of in the middle ground, but you get the point. We're trying to prevent it from getting worse. After he wears his mandibular advancement device, he reports an improvement of his quality of life by 75%. He also stopped drinking to a great degree because he realized that it was affecting his sleep. So I'm not sure how much of it was one and the other. The point is we helped improve this guy's quality of life. So what's the take-home message from the case studies? With the help of a dental office, these patients are now living an upgraded quality of life. We're not just fixing teeth. So the moral of the story, again, like the ADA position statement says, dentists play a critical and necessary role in the screening, diagnosis, and treatment of sleep disorder breathing. So where do you start? Like I talked about earlier on the Miro board, click on the document, how do I get started in DSM? There's lots of details there. Use the Miro board to get some cases started. Use that as a guiding tool so that you can hopefully navigate some of the easier patients you have in your practice. I guarantee you have family and friends that would love to be guinea pigs for this. Staff, family, and friends, I don't know why, but many husbands of our female coworkers are the kinds of people that don't go to the physicians. I don't know why that's a trend. It's something I've noticed over my career. They make wonderful patients in this arena. And then lastly, altruistic dentistry, also known as pro bono dentistry. Give this stuff away. Much of the advancement in my career came from helping somebody that didn't have the means to get something done. Well, I did something, making sure that I had proper backup and support. I am going to offer an opportunity to act in that capacity if you decide to go out on a limb through NECAID. The point is that I often had mentors in my community that were there in case I got into trouble. I obviously talked to them before I started any case. The documentation in the Miro board is extremely thorough so that you can choose the patients in a very safe manner using the tools that you'll find there. I'm sure somebody's going to ask, how much are these appliances? This is an extremely complex topic because of the fact that much of the time we're billing medical insurance. Again, topic for another day. If you're going to start around 15 to 2,000. Our office fee, we try to get somewhere around 2,800 per appliance. And then lastly, in your DSM journey, if you want to use NECAID's mastermind groups, we have a group that meets once a month. We present cases, we share ideas in the world of dental sleep medicine. You can bounce some stuff off if you decide to go down that road. There's other agencies out there, huge proponent of the American Academy of Dental Sleep Medicine in the upper left. The upper right is Dr. Stephen Olmos's international group. He has centers all around the world. Those are dental practices that you can buy almost like a franchise, like you're buying a Subway or franchising a Subway. You're franchising his protocols and his name recognition to help patients with TMJ issues and sleep issues. This is another book on the left I didn't put above because it's more for the clinician, not necessarily for your staff or your patients. Dr. Mark Collins' book, Dental Sleep Medicine Basics, great way to get introduced into this world. I'd also recommend subscribing to Dental Sleep Practice. It's a periodical, I'm not sure if it comes monthly or quarterly, but it's a pretty nice indoctrination into this world. So I talked about the NECAID Mastermind. Who are we? So it's myself. Hopefully I articulated that I do understand enough of this to help people early in their journey towards dental sleep medicine. I don't profess to be an expert in this arena. 10 years from now, I hope to be. With that said, Dr. Elizabeth Walker, interestingly enough, she's an orthodontist. She can call herself an expert in this realm. She's an orthodontist that specializes in sleep and TMD and craniofacial pain. She has several advanced certificates. If there's anybody who ever comes into contact with her, you're going to realize that this lady loves helping people. There's not a bone in her body that's not contributing towards the excitement of just improving people's quality of lives. And I'm glad to have her on the team. And then lastly, Ray is one of my good friends, and he's a hygienist in the practice, but more importantly, he's our clinical director of the dental sleep medicine part of our practice. He spends most of his day dealing with patients about everything we just talked about. But I was lucky enough to get him to join, as he was a instructor for Sleep Group Solutions for several years. So he went around the country teaching other dentists this particular realm. He has a wealth of knowledge. He's very, very smart. And he's somebody that contributes to this mastermind group immensely. So here's a few perspectives. I'm almost done. Hang in there. These are dentist perspectives on dental sleep medicine through NECAID. Dr. M said, there are few things in dentistry that fill the professional cup more than giving a patient an upgraded quality of life. What we do is important, but if we can do some of this once or twice a week, we're really going to make a significant difference. Dr. R said, although I love restorative dentistry, there's only so much I can affect restoring marginal ridges all day. If I want to change the world, I've realized that DSM must be part of my day. And lastly, Dr. Y, thanks to NECAID and DSM, I realized that I have moderate sleep apnea. If I was blind to the facts within my own body as a well-trained dentist, this guy had been in dentistry for quite some time, then I must be a solution to help others come to the same realization. And he ended with, it's my ethical obligation. So I'll let that sit with everybody for a period of time. So that's more or less the end of the lecture. I just wanted to spend maybe 2 minutes talking about a few additional resources or sources of higher dental education in your backyard. I'm assuming most of us are here in New England. I want to thank Region 1 for their very, very solid attempt at increasing the access to CE for everybody out there, including myself, offering it for free. Coordinating events like this is really wonderful. And also the national AGD. You know, I don't think most dentists understand what the AGD does for our profession. Everybody here does because you've all paid your membership, so I think you understand the value of it. If anything, maybe spread the word to your colleagues that the AGD is important. Underneath the AGD, we have the New England Master Track program. Master Track, Mastership in the AGD. This is a subsidiary of Region 1 and subsidiary of National AGD. I finished my coursework about 2 years ago and I stayed on as director. I just love this group so much that I just keep going. If any of you out there that have been there, please let everybody know that the new track 13, starts in September of this year. It only starts every 2.5 years and the seats are likely filling up fast. Please email me if you're interested or go to newenglandmastertrack.com. I believe it is. If you type it into Google, you'll find it, but I'm happy to direct people towards the people running this particular track. And then main AGD Learn at the Loaf is a little plug for my constituency. March 4th to the 6th, we have a former Pankey instructor coming to teach the things he's learned about comprehensive dentistry throughout his career. Guarantee you're going to be a good time. Plus you get to ski and write the trip off. And then lastly, I talked about NECAID. NECAID is something we're trying to increase the efficiency of continuing education and the efficiency of immersion of stuff into people's practices. So we want to take CE and make it actionable. That was my goal today. Hopefully I did a little bit of a good job there. That's NECAID's purpose. I would love to hear what everybody thinks about the Miro board. Please email me. You're not going to hurt my feelings, good or bad. I enjoyed presenting this information to everybody. So here's to upgraded qualities of life for everybody, just like Dr. R said. Thank you.
Fantastic, Dr. Roy. Thank you so much. So as a reminder to everyone, again, the evaluation survey will be sent out tomorrow. Please fill it out and submit the form to us and let us know what you thought about the webinar. Following the survey, you'll receive course attendance verification within 3 to 5 business days. If you're an AGD member, your CE credit will be submitted to AGD and filed under your reward transcript. So I think right now what we're going to do is we're going to go to our Q&A. It looks like we've got a few questions. So if you guys have anything bubbling up, please go to the Q&A at the bottom of the screen and we'll go forward. So the first question we have is, recently saw that a law firm is requesting patients to have their used air CPAP and other sleep apnea devices develop cancer to contact them. What do we know about this initiative by attorneys?
Yeah, there was a CPAP made by Panasonic, I believe. One of the filters inside there had, some particles that were shown to be connected to cancer. I don't think there were any case reports that directly linked it, but anytime there's a connection like this, law firms are always, quote unquote, chasing the ambulance to try to find people connected to it. That was one very specific type of CPAP. It was called the Dream Station, I believe. And there was a recall on it. At this point, I believe everybody that has them has since had them replaced. But if somebody has something, yeah, they can contact the lawyers and go down that road. I haven't heard anything beyond that. But I did have the idea when I read that in the newspaper to reach out to all of my patients that had CPAPs and just say, hey, if you're under this, the treatment of this particular device, maybe you want a mandibular advancement device while you wait to get the new one. Unfortunately, we didn't get around to doing that.
Excellent, thank you. When taking the Phonetic Bite, how do you determine the protrusive position, or are you only increasing vertical?
So we're actually, very good question. We're basically capturing the three-dimensional position as they speak. As we speak, our jaw does come forward a little bit. So you are capturing both the vertical and the horizontal at the same time. As you insert that device, you just want to make sure that they don't retrude the mandible backwards. But with that said, patients, once they speak and you have them bite down on the device, they typically stay right there in that protrusive manner. The sweet spot for most patients is around almost edge to edge. Most people with a normal overjet to start with, just to give you some idea where patients are going to end up.
Super. Which devices do you recommend and which do you recommend stay away from?
I think the last time I checked, there were, 300 different devices. So it's definitely not something we can dive into in the Q&A section. I would start off with Diamond Orthotic Lab. And again, I have no financial interest. I don't even know the name of anybody that works there. I think that Dr. Stephen almost owns the lab or has a lot of influence there. Without getting into it, they make a nylon appliance, which is very low profile, that is super comfortable. They don't break, they're low profile, and they hold the mandible forward. I'm a huge fan of having freedom. So the Thornton appliance or the tap appliance, where there's these metal keys that kind of lock into each other, those are rather restrictive. Patients don't really care for those, although they're effective, they're not comfortable. Again, we could go down this road. There's all kinds of different reasons why you would use different appliances. If you start doing Medicare, the Medicare only covers the Herbst appliance, which is the piston appliance. It gets really complex. Let's keep it simple. Use a lab that knows how to do this stuff so they can support you as you're starting to do this. Diamond Orthotic Lab is one. Ohlendorf Lab is another. There's probably hundreds out there. But I would make sure you use a lab that this is pretty much all they do. If you're going to use Glidewell, you're just going to get Glidewell stuff back. Nothing against Glidewell, but save them for your number 18 Bruxer crowns.
Yes, thank you for that. Next question. How do you feel about premolar extraction orthodontics? Do you think that a reduced arch increases the chance of airway obstruction?
This is one of those hotly debated topics in dentistry. And for years, I was definitely in the arena of, yes, it does cause TMD issues. Dr. Stephen almost talks about this in quite a bit of detail. There's definitely a connection, but it's not necessarily causative. The removal of the teeth and the shorter arch length leading to TMD issues. He thinks it has more to do with the palatal vault being smaller and the tongue going backwards, causing airway issues, which causes sympathetic drive, which then causes TMD. So it's a little more convoluted than just short arch form causes issues with the TMJ joint. With that said, God put them there for a reason, and there's absolutely no reason to take those out. I've had this conversation with orthodontists. You know, I'm just a general dentist, so what do I know? All I know is I have 7 employees at my practice that have TMD, and all 7 of them had their premolars out. So the jury's still out on the connection on exactly what's happening. There's definitely good reason not to do it. With that said, the orthodontic community is slowly coming around to understanding this, but we still get patients that show up every day with their premolars extracted. We're huge fans of expansion. So we do a lot of Invisalign to help patients with TMD. We don't even do IPR. So forget taking teeth out. We don't even do IPR because we want to expand. We want to create more room for the tongue. A very, very small increase in the palatal volume gives the tongue an immense amount of room to slide forward, which increases the airflow dramatically. Therefore, when we can, we expand.
Excellent. Okay, next question. Can you explain what the Miro board is again, and is there a website for it?
Yeah, so we'll send the link out when Nora forwards everything. I told Nora I'd talk to her tomorrow and give her all of the details. Miro.com is a company that makes collaborative tools. So if you work in a company where you're likely to do whiteboard projects remotely, that's where that tool comes from. It has nothing to do with dentistry. It's just a tool that I use to put all my ideas down. And then I figured out that it was a really good resource for me to share with people that has a very good flow to it with all of the links necessary. I couldn't put Word documents in the PowerPoint presentation and then have everybody go look at it later. Instead, I used the Miro board. Again, we'll provide that link to everybody in the email as a follow-up.
Yes, and please provide your email address as well so people can contact you if desired.
Yep, absolutely.
That'd be awesome. Well, looks like we're out of questions. We had a lot of people hang in. It's almost 9 o'clock. Thank you so much for your time and letting us eat up your evening. Thank you all again for joining the AGD Region 1 Speaker Series, and we'll look forward to seeing you next month. Have a great evening.
Thank you.